Welcome, everybody, to our discussion of sepsis documentation and the opportunities that we're going to have to really reflect the severity of illness and also the risk of mortality to our patients. So let's continue in this conversation, and thank you for joining. This is a disclaimer statement that we have with every presentation that I give. Every effort has been taken by the author of this presentation to ensure that the information shared was as accurate as possible at the time it was developed and presented. The primary intent of this presentation is to be informational only and to share it in a manner that is more relatable and understandable to those in healthcare with various backgrounds and levels of experience. The information that is shared is only intended to be just that, informational, and is not to take precedence over any state, local, federal guidelines, organizational policies, and/or procedures. Welcome back. So in this presentation, we're going to go over the coding opportunities associated with sepsis, severe sepsis, and septic shock. In the next video presentation, we will go into more detail about the SEP1 composite measure for severe sepsis and septic shock bundle. However, like I said, this one here will just be about the coding opportunities. So worldwide, sepsis and septic shock are the leading cause of death. And as you all know, you're well aware of it, you're practicing it. Sepsis is the presence of an infection with the outcome dependent upon early recognition and intervention. That's when we get the best outcomes. Severe sepsis is present when a patient has a condition of sepsis in addition to acute organ dysfunction. Septic shock is present when they have the severe sepsis and the persistent hypotension and a lactic acid greater than 4. Now, others may have different clinical guidelines. It is severe sepsis and septic shock or sepsis whenever you, the provider, the attending provider, document it as such. So as I discussed a little bit earlier in the previous slide, there's coding that is derived directly from you, the attending provider, documenting a condition or disease that the patient has. So from a coding perspective, the diagnosis of severe sepsis and or septic shock is derived directly from your documentation. Now, what I alluded to earlier, and as far as the SEP1 measure by CMS for severe sepsis and septic shock management bundle, that is a separate entity of a core measure. And a core measure is a measure that we externally report from our organization and organizations that are acute care hospitals with inpatient beds. They are incorporated into what's called the Inpatient Quality Reporting Program. If you have inpatient beds in an acute care facility, then you are participating in the Inpatient Quality Reporting Program that requires us to report certain quality measures. And sepsis is one of those quality measures. And there's different bundles for sepsis, but the one that we report on that is used by CMS and will be incorporated into the hospital value-based purchasing program is the SEP1 Severe Sepsis and Septic Shock Management Bundle. Now, that is meant by either the diagnosis of severe sepsis or septic shock by the provider. The provider documents that the patient has severe sepsis or septic shock, and they automatically qualify to go into the reporting and the abstraction for the core measure. And when I say abstraction, that means that certain elements are adhered to for their guidelines for compliance of ordering blood cultures, lactic acid, antibiotics, etc., in compliance with their timeline. So just so we're all speaking the same language, when the attending provider document that the patient has severe sepsis or septic shock. That is what it is, and that's reported and is reflective of the care that the patient receives. In terms of abstraction and external core measure reporting, it is a combination of either the provider documents that the patient has severe sepsis or septic shock, or by clinical criteria being met. So if the patient has an infection, SIRS, organ dysfunction, all those are met within 6 hours of each other, um, then that patient will fall into the bucket of patients that I look at to see if they've adhered to certain guidelines that the Step 1 measure has in terms of treatment and protocols. Please note that the clinical criteria for SIRS and organ dysfunction are separated in the Step 1 bundle for pregnant versus non-pregnant populations. Also, as I said before, the Step 1, the severe sepsis and septic shock management bundle, is now a part of the hospital value-based purchasing program as of January 1, 2024. They are looking at our performance as related to our baseline. Again, I'll go into more detail in a later video, but I want to give you the basics. As always, please ensure that the patient's severity of illness is accurately captured by documenting the severity of illness, sepsis, severe sepsis, septic shock. If the patient has signs and symptoms of severe sepsis or septic shock, then document that, because that tells the more accurate picture of how sick this patient is and the resources that we must use to ensure a safe outcome and good prognosis for this patient. If the documentation of sepsis, severe sepsis, and septic shock are related to any condition, then it must be linked. That cause and effect can be documented using terms such as secondary to or due to or any other similar language that demonstrates that cause and effect relationship. It is critical to link the condition to the appropriate complication code, such as do they have post-procedural sepsis, related to a device implant, or any other situation like a pacemaker, a defibrillator, an implant for a hip. Did they have sepsis during labor, sepsis due to a UTI? Please, please, please do not use the term urosepsis that I've written and read and lined through. A query should be sent to you because it is not a term that can be coded. So the query is going to allude to, are you trying to say the patient has a UTI, which is going to be a less severity of illness and risk of mortality and less resources to take care of this patient? Or are you trying to say that this patient has sepsis due to a UTI, which is more resource intensive, indicating a higher risk of mortality and a higher severity of illness? Was the sepsis following an abortion, an ectopic pregnancy, or a molar pregnancy? Was it developed post-immunization or following infusion or therapeutic injections? So again, this cause and effect and linking the condition to the appropriate complication code can only be done from the specificity and the documentation by the attending provider. Not everything is going to be definitive. Not everything is going to be final. So it's appropriate to use the terms possible, probably, or suspected. When a patient's document is having severe sepsis or septic shock, the underlying systemic infectious condition must be documented. Be careful to use templates that do not always support a congruent picture of the patient. So make sure that your documentation is clear, it is concise, and speaks to a consistent picture. So for instance, if I see patient with shortness of breath, tachypnea, delirious, with documentation in the same document that states patient is in no acute distress, this should trigger a query to the attending provider. Documentation by the attending provider as SIRS due to infection. This will trigger another query. The underlying infection must be documented. Again, we must speak to the cause and effect relationship that exists between a condition and anything else, such as sepsis due to a pacemaker implant or hip implant, because the code assignment is affected by the documentation of this complication or comorbid condition. So that really affects the codes assigned to this patient account that reflect the severity of illness, the risk of mortality, and the intensity of resources used to care for this patient. It is critical and important that the provider documents their thought process as to why this patient needs to stay in an acute care bed in an acute care facility. If there's no medical necessity to justify why this patient needs to be in an inpatient bed in an acute care facility, then the hospital will be denied payment. And we've just given away a free stay, which affects the bottom line of keeping the hospital doors open. This is an example that I've used in a previous slide, but it really does speak to the clarification that a coder will do um, retrospectively after patient's discharged, or if you're lucky enough to have a CDI specialist, it can be done within 24 hours of documentation. So when a query is sent, because we notice we have this patient that had the consulting provider that documented sepsis, but it was not confirmed by the attending provider. So a query was sent to the attending provider about the sepsis diagnosis that was found on the consulting provider's notes. And the attending provider did confirm that the patient had sepsis. So we were able to establish the primary working diagnosis of sepsis that in turn affected the diagnosis related grouping assignment with the unique relative weight assigned to it that is higher in intensity of resources than a primary working diagnosis of pneumonia due to Pseudomonas. So as you can see, the Medicare severity diagnosis related grouping on the left without clarification has a reimbursement of approximately $13,000. However, with the clarification query and sepsis being established as the primary working diagnosis, that's close to $20,000. So there's a difference of $6,700 on this account, um, just due to clarification about sepsis being the primary working diagnosis and primary code assignment. And once again, this circles back to our primary discussion about all of us having a part and playing a part in the revenue cycle of the hospital because we want to take care of the patients that come through our front doors. We want to be able to provide them with the services needed so they can have the best outcomes. Earliest intervention, earliest recognition, earliest treatment lead to best outcomes for our patients. And that's why we're all here. These are just some of the references I used in the preparation of this video, so I hope you find them helpful. This is just my second page of references that I used with some really great resources. The Surviving Sepsis campaign is really, really good. Great resources. Thank you all once again for participating in this video presentation of how we can have better coding opportunities, documentation opportunities for our patients with sepsis, severe sepsis, and septic shock. I know that we're all part of one team that wants to share the common goal of providing care for those patients in need of our services. So once again, I thank you. Have a great day.